in 2030, we will actually have performance metrics where we can demonstrate a shrinking of the disparities, of the generational disparities in health access and health outcomes amongst different types of populations.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management at the Naveen Jindal School of Management. Here at the University of Texas at Dallas, we bring together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare ecosystem. I'm Dr. Bob Kaiser, Director of the Master's Program in Healthcare Leadership and Management. Be sure to subscribe on Apple Podcasts, Spotify, or your favorite podcasting app to ensure you don't miss any of the future episodes. You can also join us online at businessofhealthcarepodcast.com. I'm pleased to welcome Dr. Jim Walton, President and CEO of the Genesis Physician Group, to the Business of Healthcare podcast. We're going to cover many topics today, and they're all related in some fashion to the consolidation of the healthcare marketplace. Welcome, Jim.
Nice to be here, Bob. Thank you for having me today, and I look forward to a great exchange with you and for your listeners.
Well, Jim, I've been waiting and wanting to have you on the program for a very long time, and I'm glad that we finally connect. And our purpose is to educate and inform our audience and try to give them insights and perspectives on some of these changes that are taking place in the industry. And you have an incredible story of experience related to quality, community health improvement, and health equity. So tell us a story about your journey and the compelling situations you encountered early on in your practice.
Thanks, Bob. I'm really very glad you asked the question, because oftentimes students forget that, this older generation of leaders have these powerful narratives that shape their lives and change the trajectory of what they thought their career was going to be. And I think that the thing that really stands out in my mind as I came out of my internal medicine training in the early 90s is that I intended to go to a small town and be a small town physician. And having left the urban training environment, thinking that I was going to leave this notion of poverty and disparities, what we call disparities in healthcare, both in the limited access to care and limited and differential outcomes of care delivery. And as I settled into my practice, I had medical school debt, and I had initiated my private practice debt as well, my business debt. I started to see this particular kind of problem that has been prevalent for at least the last 50 years of healthcare that I've been in it, which is there is a certain group of people who are unable to get preventive health care, or good continuity of health care with a chronic illness due to their limited financial circumstances, or the lack of health insurance, or lack of understanding of the healthcare system, or lack of trust of the healthcare system, as I've come to understand it. And what is so powerful after you've gone through your training and you I expected myself to be a highly trained, competent physician, that some of those experiences of seeing the disasters, if you will, of health because people didn't get the proper amount of care, that I wouldn't see that again. For some idealistic reason, I thought in private practice that wouldn't happen. Well, as it turns out, one of the responsibilities in a small town is to take care of people. We would have a rotation where we are responsible for admitting sick people to the hospital who did not have health insurance. So in our little small town, we had a 40-bed hospital, 4-bed ICU. The internal medicine doctors, would rotate about every 7 days or so. And so every seventh day or every seventh night, we'd be responsible to admit someone who didn't have health insurance and didn't have a doctor.
So that was an impactful thing for you then.
Oh, well, the consequences of it were the impactful thing is that you could do a very good job once the patient was admitted to the hospital because you had all the resources and tools and controlled environment of nursing care for any patient, and it was equitable, it was fair, and it was balanced. But the follow-up of chronic illnesses that you identified was abysmal. And as such, one particular case stands out in my mind that a middle-aged Black man came in with the difficulty urinating. He had an obstruction of his bladder, and we screened him for prostate cancer with a blood test, and it was positive. And so we told him that he needed to follow up, but we didn't provide the mechanisms for him to follow up. And as a consequence, he was lost to follow up for a couple of years. And the next time I saw him, he was being admitted to the hospital, and I was the last doctor he saw 2 years previously that he was in the hospital.
Oh, my goodness. Oh, my.
And he had, at that time, he had metastatic prostate cancer. I tell this story because it is the moment my career changed, because I was so overcome with guilt and shame about the fact that this patient was going to die this very, very tragic death, a painful death, because he had metastatic prostate cancer, and we could have helped him, and he was in his mid-50s. So I started making house calls. I committed at that time to go to his home to care for him over the course of his final weeks or months, only to find out that he didn't have a home, that he was living in a garage, an adjacent garage of his ex-wife that didn't have cement. It was a dirt floor garage in the small town that I was working in. And that's where I cared for him in his last days. From that moment forward, I was committed to do what I could to try to figure this out. What has now become labeled as health equity, this notion of avoidable morbidity and mortality that we can effectuate. We can actually change that by changing systems of care and our delivery methodology and our financing methodology. So that's kind of what drove me for the last 30, 40 years.
Okay, that's an interesting, compelling story. And it's not unlike, we had Dr. Marty McCary on with his book, The Price We Pay, and Dr. Vivian Lee, and they all had compelling stories like that, life-changing events that made them really rethink their purpose and what they were trying to accomplish. I'd like to touch base a little bit on more quality-related things. We'll get into the health equity stuff as well, but if I recall, you were years ago at Baylor, and you're involved with something that was called the Baylor Quality Alliance. That really emphasized care coordination and practice level workflow. And I think around that time, that's when the Institute of Health Improvement came up with this idea of the triple aim: patient experience, population health, and lower cost. Was that a strange concept at that time, or was that recognized? I'm trying to look at the evolution of some of the things that have transpired here.
Yeah. So the Institute of Healthcare, IHI, right, we're calling it.
Yep.
Came up with the triple aim, was really evolved out of the Institute of Medicine's kind of seminal work they did with regards to air as human. As you might remember that at the turn of the century, from the 20th to the 21st century, the Institute of Medicine, Congress asked the Institute of Medicine to identify these key issues facing the American healthcare system. And they identified this large, significant problem with quality, and quality in kind of air quotes translated into errors, right? And so that was the kind of the tip of the iceberg for the quality movement right in the beginning of the 21st century. And then that evolved into a much more comprehensive definition of quality that started to look at safe patients. Obviously, it included patient safety, but it also talked about timeliness of care, effectiveness of care, and the efficiency of care, the equity of care, and the patient-centeredness of care. And so that real focus on those 6 aims by the Institute of Medicine evolved into the triple aim that was coined by IHI. And so as different organizations around the country took on this challenge to improve quality in healthcare, that kind of initiated it kind of started inside hospitals and health systems. And it evolved where it started to include physician organizations. So now the entire kind of enterprise, even post-acute settings like skilled nursing facilities and rehab facilities and long-term care facilities started to take on this quality mantle as well. So now we have the entire enterprise across the continuum thinking about quality through these 6 dimensions that the IOM identified. And health equity, which was an area at Baylor that I was responsible for, just was one of the 6. So that was really when it began, right at the beginning, about 2002 or so. People started thinking about these items or these different elements of quality.
So later on, they came up with the quadruple aim. It's not good enough just to have a triple aim, the quadruple aim. And I guess the concept there was what? To include the health team, how there is physician burnout and issues like that kind of included in that quadruple aim?
Absolutely. I think I think that the kind of, unfortunately, what was missed early has been corrected. Let's put it that way. So it was really an oversight, which is we this, we're all patients, right? I mean, we all want our doctor to be on their game when we get to them, and so we don't want to see someone who's stressed out or burned out or not wanting to do the job or frustrated by the administrative hassles of the non-medical side of healthcare. Right? Some people call it the business side, some people call it the administrative side. But the truth of the matter is physicians and nurses and physical therapists and people who interact with us don't go to school and they're not trained in administrative activities. And so there's an intersection with the business of healthcare that can be extraordinarily frustrating for people who are wired and driven to be significant in clinical care and taking care of patients and really get rewarded psychologically and emotionally, mentally and spiritually by having meaningful interactions with people and helping them. And so the administrative activities just frustrates the daylights out of them. And so there is a element of that just really does impact the quality of care that's being delivered.
So we had the triple aim in 2007, then 2014, we got the quadruple aim. And so about 7 years apart. And we know what a single, a double, and triple is from baseball. So that quadruple was pretty easy. But is it time for a quintuple aim here in 7 years later, like in 2022? What would you add on if you could do a quintuple aim? Would that be health equity or what? What's your thoughts?
I think you could probably get to where you're breaking the camel's back with anything beyond what we're talking about. There is a real serious concern around the workforce, the healthcare workforce in America, which you would call the satisfaction or the experience of being a clinician. And this includes, obviously includes physicians, but it also includes everyone, all the other types of providers that we rely on. As the United States population ages, many more, the baby boomers are going to come into this window of time from their mid 60s to their mid 90s for potentially 30 years, where they're going to have increasing vulnerability, increasing complexity, increasing chronicity of illnesses that can be managed very effectively with medications, therefore extending the life of people but increasing the dependency of that population bubble on caregivers, not just physicians, but people who help you navigate, help you translate, help you address your activities of daily living. All the things that come with aging impair our ability to maintain our autonomy and our agency as humans. So we must be mindful of that I think to answer your question, we have to stay mindful of the quadruple aim, until we kind of get that right.
Yeah.
We're not anywhere close to getting that right at this point in time, so I wouldn't dare add anything else to it.
Okay. Well, let's talk about the categories of doctors in a way. And I like your opinion on this. I kind of think of it in terms of three groups of physicians. 5%, they really embrace the role of responsibility. And by the way, Jim, I would put you in that category. Physician leader, 5% are really physician leaders, and they take on the role of responsibility. And then I think there's probably another 20% or so that I would call influencers. They are the role models for a lot of the other doctors. And then 70% maybe are the workaday doctors. They're practicing good clinical medicine. And I want to lead into the group that you manage there at Genesis and differentiate a bit what it's like to be a doctor today. If you're getting out of medical school now versus back when you were in medical school, the choices, where do you end up going? I mean, you end up working for a large health system or a large group practice, or you work for insurers, or can you become an independent physician? So share with us your views on that and your thoughts of how that all is coming together and going forward.
That's a great question. And I think I like your stratification of, let's call it the physician marketplace, right? You think about, and they're kind of, oftentimes you could stratify those groups by personality types or temperaments, right? And you have the folks that are early adopters and they're somewhat of a risk taker. They're people who like to be in control. They're people who they get bored easily with just routine, right? They like to be pushing the edge, whether that's identifying a new way to do a surgical technique that's going to improve the quality of life of people and shorten surgery times, to folks who want to start a new business and combine different types of services together that are going to make the one-stop shopping much more convenient. And, so retail, the whole notion of retail care and consumerism is just as innovative as designing a new device that we put into someone's joint or into their eye or whatever. So those that are innovators, right? That group exists no matter what profession you're in. And this idea of professionalism is one of the things that I like to speak about, which is the idea that most physicians, wannabes, the doctors, the students here that are on the call, who aspire to be in care delivery, who aspire to be in a relationship with the patient and relieve suffering or prevent unnecessary suffering, are a unique group of people that the way they think. The same thing happens in nursing or physical therapy or rehabilitation. And so as physicians, we take that as a kind of a centerpiece of the definition of professionalism, which is to say that what we exist to protect the commons, or protect the healthcare commons that we all share. And you'll have that experience in the world of public health when we see disparities in health outcomes because there's disparities in access to medications for people with certain chronic diseases. So the problem the profession of medicine has that many physicians struggle with is this collision with the business of medicine, right? This capitalistic model that we have had and we will continue to have into the future. And so physicians, as a consequence, are looking for, kind of based on their personalities, are looking for fits, if you will. Well, what is the practice fit that is what I'm going to be most successful with? In Genesis, in the work that we do, we have many of the types that you have just described. We have physicians who have always aspired to run their own business, and they will always be a solo physician. They would just never really consider not actually having their small little staff and running their own store, running their own physician store. And they do that oftentimes at an economic sacrifice because they know they could go make more money in another role as an employee, but they choose not to do that. We have other doctors who want to practice in a community. They want to practice with several colleagues down the hall that they can have, so they're highly relational. They really love the exchange between physicians and the sharing of learning and experiences and case studies of how how you're learning and evolving the way you think about human illnesses and healthcare and healthcare improvement. There's other folks that are really intrigued by the financing of healthcare. They kind of move into this insurance industry, that really does a lot of the intermediary role, that plays the intermediary role for our financing structure. There's many people that are involved in policy development, the idea of how do we change and how do we evolve our system of care to take the best of our free market and have it work better for more people. And so what we see today, though, is these extrinsic forces, right? Walmart, let's call it, right? Or Amazon as an external force, and they're harnessing large sums of money to come and impact, if you will, or come to shape or reshape this care delivery engine for profit that's clearly seen in healthcare, because the healthcare industry, by and large, is a fairly inefficient industry. And there's a lot of opportunities to make it more efficient, and in such, as we all know in business, that is going to generate profit.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
So do you see the newer generation of physicians abandoning this, what we would call that really comfortable, trusted, engaging process with their patients? Now they're part of the big system, a big healthcare system they work for the man now, as opposed to being in charge of their particular purpose and role. Is that diminishing away as we go forward? Will that all these small practice groups sell out to private equity groups, and will there just be like 3 large airlines and 3 large hospital systems in America? What's your view on that?
Yeah, I think not. I think there'll always be this. I think what's unique about the United States economic engine and it's kind of its capitalistic model is that there's always innovators and innovation, and as you well know, Bob, it's disruptive, right? So what we're going to call is disruptive innovation is what is happening as we talk about this. And I think that one of the things I try to teach students is this one, and young doctors, is one thing: do not think we have found a model that's going to somehow dominate the marketplace. You're going to see more variation, not less. Now, granted, if you come in with a chunk of money, $500 million, you can aggregate a lot of physicians, but that doesn't guarantee that you're going to get an ROI on that. And so when these organizations start, and we all know this, we've been around for a while, we see companies that you think are never going to go out of business, all of a sudden go out of business because they actually don't get the marginal return that the investors were looking for. And they go on to the next bright, shiny thing. Our healthcare industry will get better, in my view. This is my view. Is that just disruptive innovation will make us better. So we'll have more variation in the types of models that physicians can try out. But the one thing that you can't bet on is that somehow you can permanently silo a professional physician into one kind of employment model for the entirety of their career. That bet, I would not make that bet.
Well, that's refreshing. That's very refreshing to hear that perspective. So, Jim, sometimes I think that we use the word healthcare and it covers so many dimensions. And quite often we really diminish the value of what takes place by lumping everything together into one category called healthcare. And, we start to take a closer look at what people need and what they want. They want a relationship with the healthcare team. And so I know that one of your passions is related to health equity. What are some of the persisting disparities among minority populations and the role of value-based care arrangements? What are your views on that? That's a new way of looking at things, population health. That's probably another 20 minutes on another podcast, okay?
Yeah, thank you. That's a huge idea. Here's a shorter version of that is in the new financing schemes that that have evolved since the ACA, so since 2012, right? 2010, 2012. You've got these new financing schemes we're now calling value-based arrangements. And what has happened, right, is that we're moving the responsibility for the triple aim that you were talking about, right? Quality, utilization, patient satisfaction. The industry has moved that into these networks of providers. And that could be groups of physicians, or it could be hospitals and physicians together, or it could be the entire continuum of care, taking those contracts, taking those value-based arrangements. What's so fascinating in my view, and I think I would ask people to give this some thought, is that when you have a value-based arrangement as a provider network, almost immediately you want to know your most vulnerable patients. You want to know where they are and how they're faring. So you've inverted it. You've inverted the paradigm of the way the delivery system had been running up until that moment. So as physician or even integrated delivery networks, hospitals, health systems, or physician networks, as they enter into these relationships, these value-based payment relationships, they're now developing the skill, the technology, and the social infrastructure inside their organizations to find and intervene on the most vulnerable. When we say most vulnerable, they could be isolated elderly people on Medicare, or they could be Medicaid, or they could be uninsured, or they could be CHIP, so they could be a whole host of folks that you could actually have a value-based arrangement. The ACA has given us an opportunity to insure now individuals and group them up as previously uninsured. So now our technology, we can now use AI and machine learning to identify folks leveraging social determinants and social data to elevate the concept of social need and social marginalization, and have that become the key intervention. So taking the medical model and turning it on its head. Now we have a biopsychosocial model, right? And with an emphasis on psychosocial. So all of a sudden now you get to that team-based care. And I'm gonna put a finer point on this, and I'll hush and let you ask another question. What ends up happening for minority populations who generationally have experienced a marginalization in the healthcare delivery system, they've developed a degree of mistrust, appropriately so, to a system that oftentimes has excluded them or has not engaged them in a proactive way. I believe that value-based arrangements are now giving us a moment of opportunity to say, how do we build more credibility in our system of care to engender trust, to attract folks who've been on the margins to say, that's a much more responsive organization, a group of doctors, let's say, who are thinking about my social needs. And I think because they're thinking about my social needs now, they're actually going to be able to do a better job with my medical needs, my physical needs, my behavioral needs. Now we're getting into an opportunity of integration, but I think that's being driven, if you will, by a new financing model that is bringing that accountability, cost, quality, and as you said, the triple aim, cost, quality, and patient satisfaction to the delivery system rather than it being resting, rather than where it was resting kind of at the insurance entity. And that really was the wrong place for it to rest. So I think we're making progress.
That's a very good update on that, Jim. I like that. I've got two more questions for you. One's an easy question, one's a little bit more difficult. So do you want the easy one or the hard one first?
I don't care.
Okay. All right. So if it were the year 2030, and we're sitting here looking back about what significant things had actually transformed, what would you be recognizing as major accomplishments?
In 2030, we will actually have performance metrics where we can demonstrate a shrinking of the disparities, of the generational disparities in health access and health outcomes amongst different types of populations.
Excellent.
So the one thing about the American system, right, is that we're very pluralistic. We've all these different types, and we've kind of had this large numbers of different types of communities coming into the country. But as we all know, that's also led to discriminatory behavior and bias in healthcare delivery, which then turns into unnecessary differences or avoidable differences. For example, maternal outcomes, not only to the mothers, but also to the babies, right? Just a natural space to start, right? Because at the end of the day, the baby's innocent. And so we shouldn't have differences in morbidity and mortality there. So I think by 2030, we're going to be measuring those differences, and we're going to be seeing them shrink, and we're going to be identifying successful organizations that not only have gotten the message, but also can teach how they did that.
Got it. So the easy question now, what actually motivated you to further your education by getting a master's in business administration? Why in the world would a physician want to do that? And how did it help you?
Yeah, thank you for that. So I was in my career, I had been given a great opportunity to help shape the Baylor Healthcare System's community health delivery activities in the Dallas-Fort Worth area. That responsibility came with not only establishing access points for the uninsured and the low-income population or immigrant population that Baylor took care of. So I had the privilege of doing that, but I also had the responsibility of demonstrating its value back to the stakeholders, back to the board, back to the executive leadership and the people that were financing it. The physician's education just does not give you the tools to have these conversations to better integrate the physiologic or biological information that you already have, the pharmacologic, the pathologic information that you have in your head with the science of business, the science of psychology, the science of behavioral economics, macro and micro. It seemed natural to me to not only go learn that discipline, but then to integrate that together with my medical education and my experience as a physician. And so it makes a very unique kind of package. And oftentimes you feel like your brain's at war with itself, because you're not sure which way you're going to land. But with some practice, you can harness it. Okay, the left brain will talk right now, and then the right brain.
Right. Well, Jim, this has been a good session here with you. I'm really glad to see that you are a lifelong learner and teacher. And I really want to thank you for joining us today. It's been a pleasure to visit with Dr. Jim Walton, the president and CEO of Genesis Physician Group.
Thank you very much, Bob. I appreciate it. I had a good time.
Thanks for listening to the Business of Healthcare podcast. To learn more about the Center for Healthcare Leadership and Management, go to jindal.utdallas.edu/healthcare.